And we would now move to the next part of the scientific sessions, and it would be a theme seminar. And we have it's a theme seminar that would be conducted by an outstanding personality whose excellence in veterinary surgery has benefited not only academia, but many students and leading researchers. His research interests are mainly on joint disorders, cancer, and stem cells. He has been the professor in surgery since 2008 and is a member of the Osteoarthritis Research Society International, Japanese Society of Cartilage Metabolism, European Society for Veterinary Orthopedic and Traumatology Japanese Society, and Japanese Society of Veterinary Anesthesiology and Surgery, and also the Japanese Society of Equine Science. And he has proudly provided authorship to Basawa Manual of Canine and Feline Musculoskeletal Disorders 2009. Ladies and gentlemen, please welcome Professor Masahiro Okumura, Professor in Veterinary Surgery, Graduate School of Veterinary Medicine, Hokkaido University, Japan. Sir, the floor is yours.
Thank you very much. Thank you, Mr. Chairman. The President of the Sri Lanka Veterinary Association, Dr. De Silva, and other executive members, and also organizing committee members of this scientific gathering, and ladies and gentlemen. First of all, I would like to express my sincere appreciation for giving me to join in this scientific session. I feel really honored to present our activity to you this morning, actually here in Japan in the afternoon. As the chairman introduced me, I'm a professor of veterinary surgery, and also I'm honestly speaking that I'm director of Hokkaido University Africa office in Lusaka, which is located at University of Zambia. So I'm doing surgeries not only in Japan, but also in Lusaka, Zambia. So unfortunately, last 3 months, I couldn't move from Japan to any other places. So I need to translate my language into English. It takes a bit of time. So let me move on my presentation. The title is Management of Joint Diseases in Animals. Where are we now? I would like to supply some information related to the principle of the joint diseases, which is very important for the treatment. So here you can see distal end of femoral bone. This is patella should be this place. This side is healthy joint. The other side is diseased joint. So what is the difference? That's what we have to see. So where does pain come from? The pain is a part of the treatment for us. Is very important point. So the management of the pain of the joint diseases is the first priority, because pain is related to the quality of life, and also the pain causes inflammation. And the management of the pain is management of the inflammation. So the pain is really important point. Where does it come from in the joint? One is joint capsule. Joint capsule have the sensor of the joint effusion or instability. And subchondral bone is really important point, because in the joint, okay, joint capsule, you feel is not very much pain, but subchondral bone, you can have the very sharp pain. Ligament, and so-called newborn. Newborn means, can you see that? This is kind of the osteophyte or new bone formation that's called. This is new structure of the joint will disturb of the movement of the joint. That causes pain. And blood circulation also is a source of the pain. So, as I told you that subchondral bone is the most important point of the pain because it is the origin of the sharp pain. So the subchondral bone is covered by cartilage. The cartilage is not only covered, the bone, but also provide very smooth surface, very low friction rate of the cartilage relation. So, and functionally, and also in terms of the symptoms, joint cartilage is really important. So human doctors, they do not touch joint cartilage when they do the surgery related to the joint. But for us, here, you can see is a medial patellar relaxation. In the case of the medial patellar relaxation, we cut the cartilage, then deepen of the site of the patella. We're cutting cartilage, then manipulating. That causes the big pain, the problem in the future. So if the joint is gone, if cartilage is gone, we cannot use that joint properly. So in that case, what we can do is we can do only some kind of the artificial joint, total joint replacement or something like this. So the cartilage is really, really important for us. So if the cartilage is gone, what is happening in the subchondral bones? Here is our experimental study. We made full thickness cartilage defect on the weight-bearing surface of the femoral bone, end of the femoral bone. We follow by CT, and 4 weeks after, and 12 weeks after. And also the MRI, this is a TI image. So you can see this is if joint cartilage is properly formed, the subchondral bone is as it is. But cartilage defect is happened, so some reactions of the subchondral bone to be found. And finally, after 12 weeks, maybe center of the sclerotic bone becomes necrotic. These changes could be found by MRI images also. This is histopathology. You can see, the cartilage is up to here. Sorry. This is no cartilage lesion and cartilage again. So if you remove the cartilage, subchondral bone becomes sclerotic, some point becomes necrotic. So this is what happens if cartilage is gone. So this paper published in 2017 indicated that this subchondral bone changes, the same changes as I showed you, cause big pain. So in the case, so if cartilage, if you lose cartilage by joint diseases, how can you do? In human cases, human knee osteoarthritis. So mainly elderly people who have this kind of changes. Maybe legs will open, then medial surface of the joint becomes narrowing. It means narrowing of the cartilage. So the cartilage will be gone for full sickness gone, then pain will come from the subchondral bone. So in that case, how can you do? You can make it straight of the bone. So this surgery is open wedge. This side is lifted. Then femoral bone direction is becoming this side. So it means this surface will be used before painful side will be used. So this kind of the change of the direction is one of method to avoid pain by human osteoarthritis. What happened in dogs? So this is in a case of the medial compartment disease and fragmented medial coronoid process. This is ulna. This is a coronoid process is fragmented. Coronoid process is fragmented. If you see through arthroscopy, you can find that the bone fragment here. This bone fragment is here. So if you leave this bone fragment is free, so inflammation could happen in the joint. Then finally, if the joint surface becomes reddish, it means almost all thickness of cartilage is gone. So you can see some the bloody condition of the subchondral bone. This side also. So if inflammation happened in the joint, is medial part of the joint surfaces of elbow joint is gone. So what happened to you? So our way, what we can do is one method is so-called sliding humeral osteotomy. So the same as human cases, we move weight-bearing surface from medial side to lateral side. So we cut off the stem, almost center of the bone, then slide distal bone fragment, move toward internally. Then, so if you fix by a specially designed plate, the weight-bearing side is coming to the lateral side. So this is one way, same as humans. Another method is ulnar osteotomy. Ulnar osteotomy means ulna is, and the proximal ulna is carved into the medial side. So this is a normal structure. So in that case, medial side, maybe weight-bearing side is tend to be medial surfaces. But if make it straight, if this the curve becomes straight, so weight-bearing is shared with lateral surface of the joint. So medial surface, will reduce its responsibility to support the body weight. So it's easy to walk. So pain will be reduced. So how you can make it straight is you can use this specially designed plate, put it on the side, so make it straight. So weight-bearing side will be controlled, so the time is gone. So the same thing. I can show you that if cartilage is gone, is a sclerotic subchondral bone could happen. It causes pain. So this is our hospital. So next question is how joint effusion comes. What is the trigger of joint effusion? Is many doctors cannot answer. I asked our resident veterinarians, they can't answer. So the start is of the effusion is a kind of the degradation of the cartilage. The cartilage metabolite will affect or will cause reaction of synovium. That reaction is related to inflammation. That inflammation causes more degradation. So this mechanism is really important. Then that is why we need to control of the cartridge degradation. So this is maybe the doctors in small animals knows about this. Cruciate disease, cruciate deficiency. Cruciate deficiency causes huge synovitis. Why happened? Of course, that mechanism related to the joint degradation, cartilage degradation is also there. But in the case of the cruciate rupture is related to the immunoreactions to the type 1 collagens originated from the weak cruciate ligament. So this is reported in 2008 from Belgium. So the immunomediated inflammation is related to the cruciate deficiency. And not only cruciate deficiency, but also entire joint, the inflammation is related to the somehow immunoreactions. This is reported by us. So in the case of the osteoarthritis in horses, we could find antibody to collagen type 2. So is a summary of the reactions. So inflammation is there. The cartridge differentiation is moved. Then cartridge degraded. The inflammatory cytokines is produced, and also degradative enzymes will be released from the structures. And also in the deep of the layer, it means subchondral bone, the growth factors will encourage the growing of the bone, becomes sclerotic. So these changes is there, but cartridge will not be reconstructed even by use of the iPS cells. I mean, is a state of art, regenerative medicine. Even that method cannot be repair the cartridge. So it's many trials is there using FGF and fibroblast growth factors, platelet-rich plasmas, any other things is still on the way. So our research, let me show you in our research. One of encouragement of the cartridge repair and also cartridge protection is used. We are studying on pentsam polysulfate is coming from the European beechwood is plant. So this report from our laboratory indicating that PPS, pentsam polysulfate PPS, will interfere with the inflammatory reaction in the cells. This report is by the Dr. Srandi Ujekon in Pennsylvania. When she was our student, she reported PPS will interfere inflammatory reactions in collagen-induced arthritis, means like rheumatoid arthritis in rat models. It's very beautiful model. PPS will control synovitis. So our last slide is our latest study in Mongolia. We use PPS for controlling osteoarthritis in horses. So in our research indicating that PPS will control degradation of the cartilage. So take-home message is just few words. Is the cartilage is very important structure of the joint. Treatment of joint diseases is the management of cartilage-related symptoms. Cartilage will not be reconstructed. You have to remember, disease modification, slow down disease process should be considered. The salvage method like FHO or something is only available for terminal cartilage loss. It's not for the light cases. Thank you very much for your attention. Sorry to be longer than 1 minute late. Thank you very much again for everyone for joining, for giving me opportunity to join in this, the meeting today. Thank you very much.
Thank you very much, Professor. you very much for your informative address. I'm sure you're willing to answer any questions from the audience, ones joining online, and even the ones here at the premises. So anyone with interests on this area of the area with regards to surgery, I'm sure Professor is there to answer questions. But even from the audience, he'll be accepting questions. Yes, we have one joining from the audience here.
Okay, please start.
When you use the pentosan injection, do you use it intra-articular or just a general injection? When you use the pentosan injection, do you use it intra-articular or like intramuscular or like subcutaneous?
Professor, were you able to hear the question?
I couldn't get it. Could you repeat, Mr. Chairman? Could you repeat? I couldn't hear that.
Yeah. Yeah, Professor, there's a bit of an issue here. I'm sure the doctor here would contact you via email or any other means and clarify the question. Thank you very much. Thank you very much for being with us, Professor.
Okay, thank you very much.
We would like to, before moving to technical sessions, we would like to watch a small clip from our sponsors, because without them, this would be simply impossible. And I'm sure the audience would enjoy the video that will be presented by our sponsors. Enjoy.
In the United States, there are about 2.2 million farms. We stand together and ready to continue to grow and produce the food that fuels the world.
Ladies and gentlemen, we shall now move to the technical session. The first technical session would be on clinicals, and it would be chaired by Dr. Eranda Rajapaksa, all the way from the United States, and we will be joining him online. And I would like to hand over the proceedings to the chairperson of the technical session, Dr. Eranda Rajapaksa. Sir, the floor is yours now.
Hello, good morning, everybody. I hope everybody can hear me well.
Yes, sir. Yeah. Seems to be quite clear.
Excellent. President, Sri Lanka Veterinary Association, and the EXCO members, Director General, Department of Animal Production and Health, Dean, Faculty of Veterinary Medicine and Animal Science, and all the other distinguished guests. It's a great pleasure for me to act as the chairperson of this session of the 72nd scientific sessions of Sri Lanka Veterinary Association. And let's start the sessions with a case series study, and the study is on pancreatitis in dogs. Pancreatitis has been recently have become a very common differential diagnosis in small animal practice, mainly because of the novel technologies available in diagnosis, and also due to some breed specific diseases, and also due to dietary complications in pet animals. Pancreatitis in 28 dogs. Clinical signs, definitive diagnosis using a pet side test kit, and successful management in early diagnosis is the in patients. That's the paper will be presented now. The paper will be presented by Dr. IVDTP Kumarasinghe, and it's authored by Dr. Kumarasinghe, JYC Dharmasurya, WPAU Dharmasekara, MDHS Mallikarachi, C. Amarasinghe, RGW Sirimana, and E. Rajapaksha. Dr. Kumarasinghe, the floor is yours.
My topic is pancreatitis in 28 dogs and the clinical signs, diagnosis, and successful management. Okay, pancreatitis is the inflammation of the pancreas, and clinical signs are non-specific, and it is often leading to misdiagnosis and mistaken as less serious condition. So improper and late diagnosis and management can lead to life-threatening, because it can end up with SIRS, systemic inflammatory response syndrome, and MODS, multi-organ dysfunction syndrome. It is believed that initially eosinophils are injured, and it can trigger severe inflammatory reaction, and it resulted in SIRS and MODS, which is the main reason for the morbidity and mortality in the patients. Initial diagnosis is mainly done using the compatible signalement, such as middle to old age and history of feeding high-fat diet and obesity in the patients. You can now see this in the slides. And the clinical signs such as severe abdominal pain, vomiting, and difficulty in getting up, and laboratory findings such as high amylase and lipase counts, and apart from that, ultrasound findings. And high amylase and lipase counts cannot be considered as a reliable method, because it can be increased during other cases as well, like hepatic and kidney impairment, and it is not only produced in the pancreas and other tissues as well. So none of these criteria are specific and not helpful in the definitive diagnosis. Histological examination can be considered as gold standard, but it is risky in critically ill patients. So our studies propose PET-side ELISA test kit in the diagnosis of pancreatitis. We have used IDEX SNAP CPL. CPL, it is canine pancreatic lipase, which is only produced in the pancreas and increased only during the pancreatitic inflammation. So it can be considered as the best marker in the pancreatitic inflammation. So objectives of my study is to identify common clinical signs and predisposing factors, and analyze hematological and biochemical parameters during inflammation in the pancreas, and identify relationship in between pancreatitis, SIRS, and MODS, and develop a proper treatment plan. So the method, our study consists of 28 canine cases presented during August 2018 to February 2020, and all the signalment history of the patients were recorded, and we have done complete clinical examination. Blood and urine samples were collected in order to do the urinalysis, biochemistry, and the hematology and ultrasound, abdominal radiographs also taken in order to rule out the other diseases, which is having abdominal pain and severe vomiting. All the patients were treated intensively and all were hospitalized whenever required. Treatment mainly consists of restoring fluid and electrolyte imbalance using normal saline, LRS, dextrose according to fluid and energy requirement, and pain medication with tramadol. And literature suggests that medications with ketamine and lignocaine infusions will be more successful in this severe pain management. And we have controlled the vomiting using ondansetron. And during the pancreatitis cases, nutritional management is very much important. So we have decreased pancreatic secretion by 24 hours of gut rest, which is known as resting the pancreas. And post-hospitalization dietary management is very much important. We have kept the animals strictly on low or no fat diet. There are the risk factors of pancreatitis is obesity and the fat diet, dietary problems. So we have to keep them on no fat diet. And it is reported that 43% of dogs with acute pancreatitis were obese or overweight. And the results, all dogs with abnormal CPL levels in our study are middle to old age, and 82% of were male, and all had been fed on high fat diets. So I want to summarize my study. We have diagnosed 28 cases and 13 recovered, 15 died. The 10 animals, they were presented as recumbent cases and they were severely vomiting and severely vocalizing with pain and diagnosed to have SIRS and MODS. So died during 2-3 days of hospitalization, and 2 dogs died due to severe hepatic impairment as well. And apart from that, we have seen 13 plus 3, 16 dogs. Their other systems are normal. So out of 28, 16 had normal systems other than the pancreas, and 13 recovered. Out of 16, 13 recovered. It is 86%, and 3 died because of the old age and the obesity. So I wanted to explain a little bit about the amylase and lipase content of the cases we have checked. Out of the 28 patients, 5 dogs had normal amylase and lipase levels. Only 23 had either increased amylase or lipase or both levels. So it is evident that we cannot rely on the amylase and lipase content for the diagnosis of canine pancreatitis. Characteristics of recovered pets, their hematological parameters, biochemical parameters are normal, and most importantly, they were brought for the hospital at the very first time the client noticed the changes in their behavior and the temperament. That is the very much important point here. So I wanted to describe what are the signs of the dogs who died with abnormal CPL levels. They have severe changes in the hematology and the biochemistry and the other systems. So for an example, hematological changes such as severe leukocytosis, thrombocytopenic, anemic, we have noticed. Apart from that, their liver and kidney profiles, all the systems are affected. So this graph exhibits mainly the changes of the creatinine and blood urea nitrogen in the cases of abnormal CPL dogs who recovered and who died. You can clearly see that recovered pets had normal BUN and creatinine levels. They are within the normal range, but in the died patients, it's very high. So all these values are taken during the presentation of the animals. And the Next graph show the changes in the ALT and ALKT levels. We can be considered as the liver profile. And same changes we have noticed in green color shows you the recovered PEGs, and the dyed color, it is red color, it's the dyed. So recovered initially had the normal levels, but the dyed, initially it's very high. So during the recovery period, we have done periodical checkups every weekly in order to monitor their clinical signs, changes of the clinical signs, and the changes of the amylase and lipase levels and the CPL levels. And we have noticed that within 2 weeks, every counts get into the normal range. So this is I'm going to the last slide of my presentation. So I want to emphasize very few points as a take-home message. Pancreatitis, it can lead to SIRS and MODS, but prognosis primarily depends on the early diagnosis and clinical condition at the time of admission and proper medical and nutritional management. And changes in the amylase and lipase counts cannot be considered as a reliable method of the pancreatitis. Apart from that, we can use CPL, canine pancreatic lipase. There are several commercial products available. So as the best marker during the pancreatitis diagnosis. Thank you.
Thank you very much, Tirani, for your presentation. And now the paper is open for questions.
Yes, after the pancreatic inflammation, usually due to the acinar cell damage, due to the systemic inflammatory reactions, kidney and liver all going to damage. That's why the kidney and the creatinine, blood urea nitrogen counts getting increased. Because of all these cases, CPL is abnormal. There is 97% sensitivity in the pancreatitis and the CPL abnormal levels. So we can diagnose as the abnormal pancreas is the reason for the damage of the kidney and liver.
When we are having kidney patients in our clinics, that we have to always go for this pancreatitis important also.
Better to go for these only if you are having vomiting and severely abdominal pain, patients with severely abdominal pain. Better you can think about the pancreas as well. When you have high pancreas, kidney and liver profiles, better to go for that diagnosis as well. It will make the helpful. Yes. Sorry, I didn't get that. Different. The readings are same. This case series we have diagnosed as acute pancreatitis because the abdominal pain and severe vomiting is sudden onset. So we can diagnose these cases as acute, and in the chronic cases also it's increasing, decreasing, and the conditions are same.
What is the cost of one CPL test? What is the cost of one CPL test?
Cost of one CPL test, it is in IDEX, it's 2,600, but there are several commercial products which we can use in to helpful in our diagnosis. No, it's canine specific. There are feline specific products as well.
I have one question. Did you ever think about analyzing the cases who died? Were they late presenters?
Yeah, yes, madam. They are late presenters. That's why the recovered ones, owners brought the patients as soon as possible. They have noticed the changes. But other cases, the clinical signs are for 1 week, 2 weeks. But at the last moment, they have brought the patients when they are recumbent. So I think they are late. Acidemia was higher, yes. All died cases.
I don't see any questions on the Q&A panel or the chat window. So if there are no other questions from the audience, live audience, shall we conclude the session?
Thank you very much.
Thank you very much, Telni. Before moving on to the next paper for the audience, I can see 64 people are joining in. If you have any questions for the authors, you can type it down in the Q&A session or the chat box. Then I can direct those questions to the presenters. So the next paper is on surgical management of humeral diaphyseal fractures using dynamic compression plate. The paper is by P.G. Ishwara, K.D.C.K. Hemachandra, D. Rajapaksha, N.H. De Silva, and G.S. Premachandra. Dr. N.H. De Silva will be presenting the paper. The floor is for you.
Thank you. My topic is surgical management of humeral diaphyseal fractures using dynamic compression plate. Introduction. Fractures of the humeral diaphysis are amongst the most common type of broken bone seen in dogs and cats. Numerous methods have been described for surgical management of humeral diaphyseal fractures. DCP, LC-DCP, locking plate, intramedullary pins. The dynamic compression plate is a special plate developed by the AO, and it is the standard plate type for many decades in the veterinary profession. Goal of surgical management. The primary goal of fracture treatment is to achieve a healed fracture with normal bone alignment and promote immediate function of the affected limb without compression, tension, torsion, and bending. Case report. Present report describes 12 cases of humeral diaphyseal fracture correction using DCP plate and screws in dogs and their management in Citipet Animal Hospital, Aturgiriya, during January 2018 to February 2020. It includes 6 indigenous male dogs, 3 indigenous female dogs, 3 German Shepherd male dogs. Mean age of patients with DCP fixation was 6 months to 3 years. Road traffic accident and fall from height were the most common mode of injury. This is Johnny male 8 month, Chuti male 2 year, Lucky female 1 year, and Rovi male 3 year. Type of fractures: transverse, oblique, spiral, comminuted, avulsion, impacted, fissure, and green stick. History: road traffic accident and fall from height. Clinical signs: General clinical examinations followed by physical examination revealed presence of swelling, laminus, pain, and crepitus. Confirmative diagnosis of humeral diaphyseal fractures were made by radiography. This is Johnny, transverse fracture in left humerus. Chuti, oblique fracture in left humerus. Lucky, transverse fracture in right humerus. Rovi, comminuted fracture in right humerus. Materials and methods. These are equipment used in the surgery and pre-medication. Atropine sulfate was administered subcutaneously prior to sedation with psilocin. Induction of anesthesia, propofol 2 mg per kg IV followed by intermittent administration of propofol. This is the plate size guide. Surgical procedure. A skin incision was made from the cranial border of the tubercle of the humerus to the lateral epicondyle distally. Subcutaneous fat and brachial fascia were incised along the same line, being carefully to isolate and protect the cephalic vein. Brachial fascia was incised along the border of the triceps. Use caution when incising the fascia along the cranial border of the triceps overlying the brachialis muscle until the radial nerve is visualized. Once the nerve is isolated, the brachiocephalicus and superficial pectoral muscles were reflected cranially and the brachialis muscle caudally to expose the proximal and central humeral shaft. Brachialis muscle was reflected cranially and the lateral tricep muscle caudally to expose the distal humeral shaft. DCP plate was placed on the aligned fracture fragments of the humerus. The bone was drilled using 2 mm drill bit. The depth was measured using depth gauge and screws were applied. The brachial fascia, subcutaneous tissue, were sutured using Vicryl 2-knot and the skin with 2-knot nylon. This is the animated video clip of the surgery. This is Johnny, Chuti, and Lucky after the surgery. Post-operative management, ceftriaxone, metronidazole, ranitidine, meloxicam, single dose of tetanus toxoid, and patients were discharged after 5 days of treatment and the owners were advised to restrict their movement. Skin sutures were removed 10 days post-operative. Results. This is Lucky after 5 days, Rovi after 10 days, Chuti after 10 days, and Johnny after 6 months. Discussion: the patients were walking normally from post-operative day 2. Full recovery with no complications was observed after 6 weeks upon radiography. Surgical repair of humeral diaphysis fractures using DCP plate can be considered as an effective means of managing humeral diaphyseal fractures, which produce excellent result, and the advantages being early mobilization and rigid fixation. It offers remarkable improvement in the limb function with good fracture stability till the completion of the bone healing. Acknowledgement, Citipet family, owners of the dogs, Video Team Private Limited. Thank you.
Thank you very much. Now the paper is open for discussion.
When sometimes the dogs met with road traffic accident, there are open fractures and there is deep wounds, and it might contaminated with soil and mud. So we give tetanus toxoid for that indication.
For selecting the combination of antibiotics, ceftriaxone and metronidazole in all the surgery?
We usually give to cover the gram-positive and negative anaerobic and aerobic bacteria. So we use that. For that, we use ceftriaxone and both ceftriaxone and metronidazole. We usually give for 5 days. Usually we give for 5 days, and then we check the whether it's contaminated or not. We used to continue with further 5 days, furthermore around 5 days.
Propofol alone, I mean, the other combination. Why do you prefer propofol? I mean, after cytosine?
Usually it is more safer compared to other anesthetists. So we use propofol.
Adhika, of the dogs you have shown, like shown 4 dogs,
yes.
What kind of fractures did you encounter?
Like most of the time it's oblique fractures, oblique and comminuted fractures.
All those 4 patients, do you think they are bone density? Were there any cases which had signs of osteoporosis, which had post-surgical complications? Do you have any follow-up of those cases?
Madam. And actually, there were none of post-surgical complications. They healed usually, same as earlier, and the activity also same. So.
Dr. De Silva, there is a question from the Q&A panel here. Dr. Alexandria de Lima is asking the question. And the question is on orthopedic surgeries are extremely painful. Current pain management for these procedures involves intraoperative multimodal analgesia. Was this performed during your surgeries?
Sorry, I couldn't hear the question. Analgesia after post-surgical. Post-surgically, yes, we. Yes, we. Yes, yes, we gave meloxicam. We gave meloxicam. Yes, ma'am.
Okay, so that is all the time we have for the presentation. Thank you very much.
No, only meloxicam we gave.
Hello. Yeah, that is all the time we have available for the presentation. Thank you very much. And our next presentation is on, again, surgical procedures on the femur. So it might be a little surprising for you to hear that in 1953, in our SLVA first journal publication, one of the papers was on femoral surgeries by our great professor, Professor Kodituaku. And following the same trends, now we have come a long way. And today's paper is on femoral head and neck osteectomy in dogs with disorders of coxofemoral joint. The paper is authored by Dr. D.M. Sirivardhana and Dr. J. Kollure. Dr. Sirivardhana will be presenting.
Good morning, dear colleagues. My presentation is on femoral head and neck osteectomy in dogs with coxofemoral disorders. The femur is attached to the acetabulum in the ilium. This is the normal anatomy of a joint. So the abnormalities could be hip dysplasia, femoral neck fractures, head necrosis, femoral head dislocation. All these hip joint abnormalities manifest as pain in the movement. Hip dysplasia is the most common one. The true cause is not very clear. There is genetic factor involved and also multifactorial developmental disorder. At birth, hips are normal. During development, early dysplastic changes are observed. What happens there is synovial fluid volume increases and the ligament stretches, the round ligament. As a result, thickened and stretched joint capsule moves the femoral head laterally. In the worst cases, it moves dorsally, resulting joint inflammation and osteoarthritis. In this picture, you can see here, this is animal with dysplasia. On the right side, you can see it's moved quite badly laterally. And this is the same dog after 3 months. It has moved dorsally. Animals feel pain during movement, causing limb, exercise intolerance, and sometimes mood swings. The best method to overcome this problem is the total hip replacement. However, when such facility is not available, femoral head and neck osteectomy is recommended as a salvage procedure. FHNO forms as a false joint with fibrosis, allowing pain-free movement because there is no bone-to-bone contact. We have selected 5 dogs who had hip dysplasia, in addition 1 with neck fracture and 1 with hip dislocation. They were all young, active males. They had limp, muscle atrophy, exercise intolerance, and pain on movement. History, clinical signs, and examination was done. Orthopedic and neuro exam both is important because if there is any neuro deficits, this surgery is contraindicated, and the radiographs also were evaluated. All hip dysplasic animals had medical management before, but it was not successful. In hip dysplasic animals, the dorsal acetabular rim coverage was less than 50%. This is one picture to show the dorsal acetabular rim coverage is less than 50%. In this X-ray, you can see the right side is good. It's more than 50% the coverage, but the left side is less than 50%. This is another candidate who had a neck fracture. The arrow shows the neck fracture. Animals were pre-medicated with morphine and meditomidine, induced with propofol, maintained with isoflurane. Antibiotics were given 30 minutes before the surgery and 90 minutes later. Meloxicam was given as an additional painkiller. Dogs were clipped extensively up to the perineum to prevent contamination, and then they were scrubbed. They were draped. The distal limb was bandaged with autoclaved bandage. By this, we can move the leg without breaking sterility. They were placed on lateral recumbency. Then we use the cranial lateral approach. This muscle is important. This is the deep gluteal muscle. Tendon of the deep gluteal muscle was partially or fully transected to open into the joint capsule. This is the magnifying view of the proximal femur. Excision line is important. We use the excision from the medial aspect of the greater trochanter to the lesser trochanter. The black arrow shows the proper excisional line. We should not cut the lesser trochanter here because we need to preserve the muscle attachments, because this surgery relies on muscle strength. So preserving these muscles are very important. So this is the cut surface. In order to remove the neck, we need to rotate the femur backwards, and then eventually the stifle joint upwards. On the second picture, you can see its stifle joint is upwards. This video shows the cutting when we use the oscillating saw to cut the neck. When cutting, heat generates, so we need to cool down with saline to prevent tissue damage. Here is the head and neck removed. Remaining femur cut surface was smoothened out to prevent rough edges and spikes. If these are left, it causes irritation and causes pain again, and it's a surgical failure. This is the X-ray after removal of the head. You can see on the right side, after removal of the head and the neck. And then the surgical incision was closed routinely. These are a few other pictures from other patients. This is on the left side. In this surgery, pain control is very important because animals should move quickly. Unlike other surgeries, in this surgery, dogs were walked soon after recovery on leash. Therefore, we have given morphine every 4 hourly until recovery. Owners were given written instruction for short walks, gradually increasing over the time period of 3 months. Owners were advised on the diet to control the body size to the optimal level, because if the animals get obese, again, they can't bear the weight properly. So it's important to control the diet. All dogs were able to bear weight within 24 to 48 hours after surgery. They were moving freely after a month. Full extension of the limb is a limitation. However, all dogs were happy, cheerful, bouncy without pain. Muscle atrophy was less in all dogs, and the owners were satisfied with the results. In conclusion, excellent results was found from surgery with pain-free movement, improving quality of life. Bigger dogs also do well with the surgery if the surgery is done properly. The books indicate the medium-sized dog, it is the best way. However, we can do in bigger dogs also. Regular exercise and maintaining the body weight is also very important. FHNO can be recommended in Sri Lanka for dogs with hip dysplasia or any other coxofemoral disorders as a salvage procedure. This is the same dog after 48 hours of surgery. He's walking with the limp. This is another dog after 3 months of recovery. Thank you.
Thank you very much, Dr. Dayani. Now the paper is up for discussion.
And my question is, when operators
Yes.
have bilateral
Yeah.
dysplasia using only one side,
We did one only, because one at a time, because it's too painful to do both at the same time. Some people do both sides, but we didn't want to take that chance because we wanted proper exercise and like see whether this animal recovers fully. If the owners request, if there is any problem with the other leg, yes, we do the other one later.
Interesting presentation. Bilateral hip dysplasia on young puppies called polycystic syndrome. Is there any treatment for that type of bilateral dysplasia? Especially young puppies.
Young puppies, we do the medical management first.
Due to polycystic syndrome. So, any management plan for those type of puppies?
Any special management you're talking?
Yeah, the cause of bilateral hip dysplasia due to polycystic. So any management rather than going for surgery?
We always select these cases with the bilateral hip dysplasia also after when the medical management fails. Initially, we don't go for any of the puppies or adults. That I'm not very aware of.
Why you select femoral head amputation instead of total hip replacement, that type of situation?
We are not qualified enough to do the total hip replacement at this stage in Sri Lanka.
Length of the bone is short.
Yeah.
The problem so did you have any other mechanism techniques?
There is no mechanism as such to manage because it's obviously going to get a little shorter without the head and the neck. But the pain is the main thing that goes away. They can do all the routine exercise. Other than full range of motion of exercise, they can be very bouncy, happy, all that. So the shortness is a problem in this particular surgery. But the owners were very satisfied because animals were very reluctant to walk before.
And I think that's all the time we have for questions. Thank you very much, Dr. Dayani. So let's move on to our next presentation. The paper is on foreign body obstructions in gastrointestinal tract of dogs, a retrospective study. The authors, RMNS Nwanshika, GADKK Gunatilaka, MGTM Prasadini, DDN De Silva, and HMS Vijayakon. Dr. RMNS Nwanshika will present the paper.
Hi, good morning, everyone. I would like to welcome you all to the presentation on foreign body obstruction in gastrointestinal tract of dogs, which is a retrospective study. As you all know, foreign body obstruction As you all know, foreign body obstruction in gastrointestinal tract is a veterinary emergency, and also it represents a diagnostic challenge. Foreign body obstruction can be mentioned as one of the commonest indications for laparotomy in dogs. There are two foreign body obstruction kinds, partial obstructions and complete obstruction. In partial obstruction, it allows limited passage of fluid or gas. Complete obstruction doesn't allow fluid or gas to advance past the obstruction site. Commonest obstruction sites are esophagus, pylorus, small intestine, and colon. When diagnosing foreign body obstructions, first comes the history. Owner may complain about the observation of foreign body ingestion or the scavenging behavior that lately present. And the prominent clinical signs are vomiting, shock, abdominal distension, abdominal pain on palpation, absence of feces, lethargic behavior, anorexia or hyperexia, and severe dehydration. When diagnosing, when we come to diagnose after the clinical signs, we can aid diagnostic methods like survey radiographs, ultrasonographs, and endoscopic examinations. They can direct us to laparotomies by confirmation of the foreign body obstructions. Objectives of my study are to report the clinical presentation of foreign body obstruction in gastrointestinal tract, and to identify the predilection site of obstruction, and to observe the types of objected recovered, to investigate the efficiency of imaging techniques. When it comes to material and method, the study was done as a retrospective study. Clinical records were checked between year 2018 and 2020 that have been presented to veterinary teaching hospital. 13 cases were selected which had foreign body obstruction in gastrointestinal tract. Clinical records of those 13 cases were thoroughly examined and confirmed as having foreign body obstructions. Important clinical informations were recorded in order to analyze. X-ray reports were reviewed, and also additional diagnostic aids comments were rechecked. Then the information were categorized to easier the study. Recorded informations are history, signalement, age at presentation, clinical signs, physical examination findings, clinical pathological data, diagnostic procedures, intraoperative findings, location of the foreign body, outcome, and if patient was died, necropsy results. Results and discussion. As mentioned before, 13 dogs with foreign body obstruction in gastrointestinal tract were included in this study. Among these 13 cases, there are 7 male dogs and 6 female dogs. The age range goes from 2 months to 7 years. And the represented breeds are crossbreed, Dachshund, German Shepherd, Boxer, Rottweiler, Bull Mastiff, Shih Tzu, Labrador Retriever, and Cocker Spaniel. The incidence of clinical manifestation of major clinical symptoms in dogs suspected of gastrointestinal obstructions are recorded as the table shows. Regurgitation or vomiting was recorded as 53.8% in patients and anorexia in 61.5%. Enlarged abdomen in 46.1%. Pain on abdominal palpation in 15.4% and absence of feces or scanty feces in 46.1% and hypersalivation in 15.4%. 61.5% of patients showed lethargic behavior, and the history said that 46.1% of patients having scavenging behavior. After the clinical signs, gastrointestinal obstruction confirmation was done with aid of diagnostic images. Abdominal or thoracic radiographs were taken in all 13 cases, and foreign bodies were diagnosed in 8 of 13 cases. 1 of 13 cases underwent ultrasonography to confirm the diagnosis, and another case was confirmed by using endoscopic examination. And enterotomy followed by exploratory raplotomy was performed in 4 out of 13 cases when the diagnosis was not able to obtain through clinical examination. The diagnostic image of the patient showed related clinical signs and history of scavenging behavior. Additionally, 1 patient suspected foreign body obstruction in gastrointestinal tract died during diagnostic procedure, and postmortem findings revealed the presence of toy parts in pyloric region. There are some radiograph images of foreign body obstruction in gastrointestinal tract of dogs that ultimately led to laparotomy surgeries. Let's go through each images. Image A is showing lateral abdominal radiograph of a radio-opaque object located in intestinal loops. And the image B, lateral thoracic radiograph showing presence of radio-opaque metal hook in the esophagus. Image C is a lateral thoracic radiograph showing presence of radio-opaque bony part in the esophagus. And the D is a lateral thoracic radiograph shows a radio-opaque pressure cooker vent knob in intestinal loops. When talking about the incidence of foreign bodies lodged in different places in gastrointestinal tract, 3 foreign bodies out of 13 found at esophagus and 8 were from small intestines. Furthermore, both pyloric obstruction and colonic obstructions were recorded as 1 from each. Antimesenteric enterotomy, gastrotomy, esophagostomy followed by thoracotomy are the standard techniques for removal of foreign bodies lodged in intestines, stomach, and esophagus respectively. The incidence of complete and partial obstruction is reported as this. There were 6 complete obstructions and 7 partial obstructions out of 13 cases. Here you can see some isolated foreign bodies, including a hairband, a balloon, a metal hook, nails, and metal toy element, and some stones. Conclusions of my study are, according to the current study, most common clinical signs are vomiting, absence of scanty feces, enlarged abdomen, and anorexia. A thorough and careful history recording, observation of clinical signs, radiographic, sonographic, and endoscopic examination may be helpful in identification of canine foreign bodies in gastrointestinal tract. This diagnostic method should be correlated with the physical finding in attempt to diagnose condition as soon as possible. And the early recognition of complication is essential for a successful outcome. And I would like to thank all the academic and non-academic staff in Veterinary Teaching Hospital and the dog owners. Thank you.
Thank you very much, Dr. Nwanshika. Now the paper is open for discussion.
Have you noticed any leakages from?
Recently, the surgeries that done recently, there were no leakage of peritonitis were recorded, but from the year of 2018 to 2020, we did the study. We followed up like 10 cases out of these 30. There were 2 cases that has died after the complications, after surgical complications, most probably peritonitis cases.
Means that the dog had a pin or something. It's a part of the system, right? You have any idea?
A metal hook.
It's a part of the body.
Yes.
Have any idea? Or I mean, on the study you
Manually, we removed it manually after sedate. We did it.
You will open up the site, right?
Yeah. Yeah, I have. Yes, it's done recently. I wasn't at the surgery, but I knew about it.
Nwashika, there is a question from the online audience. Hello?
Yes, sir.
Yes, yeah, the question is about the dog that you mentioned that died during the examination process. So they're asking what is the cause of death for that dog?
There was a toy element that stuck in pyloric region. It wasn't obvious at the first in X-rays. So animal was very weak to take for a surgery as he presented here. So we were managing him to make clinically fit to a surgery. During that period, animal died.
Yeah, and that question was posed by Dr. Harsha Ariratna. Okay, with that, we will conclude this paper, and then we will move on to the next one. Thank you, Nwanshika. So our next paper is on a quite rare clinical condition. It is on linguinal calcinosis circumscripta in a young dog. The paper is authored by M.G. T.M. Prasadini, G.A.D.K.K. Gunatilaka, R.M.N.S. Nwanshika, B.M.D.N. Kularatna, and H.M.S. Vijayakun. Again, the presentation will be done by Dr. R.M.N.S. Nwanshika.
When this voice goes over the internet, it's a little sluggish sometimes. So try to speak a little slower. Because you are so good at presenting, you speak fast, but as you can't, right? Okay, thank you.
So again, hi everyone. Now I'm looking forward to discuss with you about an interesting finding that we were able to came across during clinicals at Very Teaching Hospital, which is lingual calcinosis circumscripta in a young dog. First of all, I'll provide you with some background introduction on what is calcinosis circumscripta. Calcinosis circumscripta is an uncommon disorder characterized by calcium deposits in soft tissues in both humans and animals. These calcium salts consist of hydroxyapatite crystals or amorphous calcium phosphate. The disease occurs most often in large breed dogs under 2 years of age with higher incidence in German Shepherd, Rottweiler, and Labrador Retriever dogs. The condition is characterized by the formation of nodules in sites of previous trauma, pressure points, or bony prominence. Calcinosis circumscripta, as the name suggests, it is a circumscribed form. However, there are several unusual anatomic locations for calcinosis circumscripta were identified, including thoracic wall, thoracic spinal cord, salivary gland, and tongue. Although pathogenesis of calcinosis circumscripta remain uncertain, early diagnosis is essential as this condition is surgically curable and recurrence is rare. As calcinosis circumscripta can mimic malignancy, histopathological diagnosis is essential to come to a diagnosis. In these pictures, you are seeing lingual calcinosis circumscripta. Even though calcinosis circumscripta is more frequently occur under foot pads or over bony prominence, similar lesions are less commonly seen in the tongue and buccal cavity. We have found little published clinical information about the oral lesions. And this case I'm about to present describe calcinosis circumscripta affecting the tongue of a young Rottweiler dog. So let's move on to the clinical case that we came across. Roger is a 1-year-old male Rottweiler dog which works for police force, presented with the complaint of white spots under the tongue which were found by the trainer since a month. There was a history of giving calcium supplement for 6 months, and the patient's appetite and general state of health had undergone no alterations, and the vaccination protocol was current. Other than having tongue lesions, the dog was bright, alert, and responsive with normal behavior, and all the other vital parameters were within the normal ranges. The dog was anesthetized to permit a detailed examination of the mouth, and small white multifocal nodules masses were felt and seen immediately under the epithelium of the ventral surface of the edge of the tongue, as you can see in these pictures. Then we came to a differential diagnosis. Differential diagnosis list was prepared based on the physical and oral examination. List included abscesses and foreign body as it gives chalky content when it's slightly squeezed, and the candidiasis as it gives white patches on the tongue and other areas of the mouth or throat, and chronic inflammation of unknown etiology. Eosinophilic granuloma can cause moist bumps scattered on the skin surfaces, so it came to our differential diagnosis as well. Then the rare condition lingual calcinosis circumscripta was suggested by the surgeon, as this shows the same kind of lesions. And uremia, which can cause oral ulcers, came to the differential diagnosis. Finally, the neoplasia, which came as a differential diagnosis because it looks like an abnormal mass growth. Hematological and biological tests, including white blood count, red blood count, platelet, creatinine, blood urea nitrogen, total serum calcium level, creatinine phosphokinase, serum phosphorus, and cortisol level were requested. However, analyzed blood samples showed that the dog had normal activities of enzymes and mineral contents. Especially, we paid attention on creatinine phosphokinase and serum calcium and serum phosphorus, which are known as indicators of nutritional myopathy and metastatic calcification. As the appearance was consistent with calcinosis circumscripta, it was tentatively diagnosed as a lingual calcinosis circumscripta, and microbiology culture test was negative for presence of bacteria or fungi. As the animal was clinically fit for a surgery, the surgeon was decided to take the animal into the theater and remove the masses. First, animal was given amoxicillin as a prophylactic antibiotic, and the dog was pre-medicated using chlorpromazine, and meloxicam also given as an analgesic. The induction of anesthesia was done using propofol. During the surgery, an incision was made in the mucosal surface of the ventral tongue, reaching the smooth muscles of the tongue, maintaining 1 centimeter margin of grossly normal tissue. And then the wedge-shaped incision was made on the ventral surface of the mass, completely excised. The procedure was done to all the masses on the ventral tongue, and bleeding points were cauterized. Tissue was fixed immediately in 10% neutral buffered formalin and sent to the histopathological observation. As post-operative management, animal was prescribed with amoxicillin, meloxicam. Patient had no signs of pain or discomfort during this period, and same antimicrobial therapy and balanced diets were prescribed for 7 days following the surgery. Histopathological findings, examination of masses reveal a normal stratified epithelium with underlying submucosa containing multifocal amorphous calcification without tissue reaction. You can see it from the blue arrow here. And finally, we came to a definitive diagnosis. This condition was diagnosed as lingual calcinosis circumscripta, which is a rare condition as I mentioned before. There are 3 major types of calcinosis circumscripta. They are dystrophic, metastatic, and idiopathic calcinosis. Dystrophic calcinosis occur in a specific areas of tissue damage, which may be due to injury, necrosis, inflammation, or neoplasia. Serum calcium and phosphate levels are normal in this type. And the metastatic calcinosis is associated with abnormal calcium or phosphate metabolism, such as hypercalcemia, hyperphosphatemia, which can be derived by chronic renal failures, end-stage renal diseases, or vitamin D toxicosis. Idiopathic calcinosis occurs without identifiable causative factor. In small animals, dystrophic and idiopathic calcinosis occur more frequently than metastatic calcinosis. And the presented case was identified as having idiopathic origin as there were no alterations in calcium or phosphorus levels. Apocrine gland of the oral mucosa degenerates, producing a focal area of calcification due to necrosis. The dog recovered well after surgical removal of the masses. 2 weeks on follow-up, wound were healed and resumed on its normal duties in the police force, and after the checking after 5 months, there were no recurrence were present. And the points to remember are repeated trauma or inflammation may lead to tissue necrosis and subsequent dystrophic calcification. Diseases causing high calcium level may cause metastatic calcification. Surgical resection of the lesion is likely to produce a cure, and when diagnosed this condition, animals should be examined for the presence of an underlying disease process. And I would like to acknowledge academic and non-academic staff in Veterinary Teaching Hospital and all the Dr. Ashani Palkubra and pre-internee Ms. Chaturi Rodrigo, Department of Veterinary Pathobiology, and Asgiriya Police Dog Kennel Candy. Thank you.
Okay, thank you very much, Dr. Vanshika. And the paper is open for discussion.
Before taking the surgery, we didn't have any idea about the, before the histopathological examination, we didn't have idea about condition for definitively. So we gave prophylactic antibiotic because it could be abscess or something. Sorry. Oral mucosa, I was talking about the oral mucosa apocrine gland, madam, not in the tongue. Size.
We can't hear the question for the online audiences.
Can't hear the question. Can you repeat it, please, madam?
You said there are apocrine glands, no? Are you referring to salivary glands or sweat glands?
Salivary gland. Yeah. No, in the oral mucosa, sir. In tongue, there were no apocrine glands.
not enlarged?
No, madam.
And when you said animal was given balanced diet, what does that mean? Like, was he not given a balanced diet earlier, or is there a specific diet that you all have recommended?
But we asked to manage the calcium supplements that they gave. Because this is a calcinosis, it could lead to a extra calcification. We asked them to manage the calcium level. Calcium, he was under calcium supplements.
Balanced diet. You recommended the balanced diet. What did you do?
We half the dose of calcium supplements that gave. That's normal diet, madam. He was on a good diet management plan. It was continued.
Okay, with that,
Take the food and what type of food they are giving, liquid diet or solid diet. I mean, after surgery. So how many hours you keep him without like food?
After surgery, day after surgery, it was okay to have the liquid form diet. Gradually, within a week, he was under the solid diet.
okay, we will conclude the presentation. That's all the time available for us at the moment. Thank you very much, Nwanchika. Okay. The next paper is on porcine reproductive and respiratory syndrome. Disease economically and health-wise in swine. And there's a comprehensive review published in SLVJ in year 2006 by Kotalavala and others. And the current research paper is on an outbreak of porcine reproductive and respiratory syndrome in 2 breeder farms. Clinical presentation, diagnosis, and control strategies. Authors are WASM Premaratna, KG JS Disnaka, WCI Pereira, GMCR Karunaratna, and CG Vijay Singha. The presentation will be done by Dr. WASM Premaratna.
Second. Yeah. Presentation for the cell. Yeah. Yeah.
Okay, Samira, before you start, please let me make a small comment. There's a request from our virtual audiences that they have questions and they need them to be answered. So for the virtual audience, I want to request, please post your question as the presentation is going on, so I can give priority to you before passing the mic to the live audience at Peradeniya. Thank you. Okay, Samira, floor is yours.
So I'm going to share my experience. I'm Samira from NL National Livestock Development Board, the farm animal veterinarian. I'm going to share my experience during last year, which I encountered with an PRRS outbreak case in our farm. So the first I would like to introduce briefly what is PRRS. Actually, it is a single-stranded RNA virus, belongs to family Artiviridae. Also, it has two genotypes, European and North American versions. And the major problem is it compromises the immune status of the animal. So, like you experience in nowadays in COVID situation, it is similar to quite similar to COVID-19 in pigs, right? So they can't wear a mask like us. So and with the immune suppression, some concurrent infections are possible. Bacteria like Haemophilus parasuis, Aspergillus multicida, also Mycoplasma pneumoniae, and it persists in tonsils and lung macrophages when the infections are ongoing, and the virus can be transmitted through contact each other, affected pigs and unaffected pigs, and aerosol transmission, and the venereal transmission another way when they are met each other through the semen, and especially drinkers and feeders, while they are in a group pen, they share each other. So like that, the virus can get infected to pigs. Also, in Sri Lankan situation, it's quite common, the swill feeding of pigs. So it is more common with the untreated swill feeding, especially in field. And the case presentation, it has happened last year, 2019 in November started, and the location is Puttlam district. The two breeder farms belongs to National Livestock Development Boards. The herd sizes were Farm A has 499 animals and Farm B had 952 animals. The comprise of large white, landrace, and Duroc pure breed in Farm A, and Farm B having large white landrace crossbred females and Duroc males. Also, there are piglings. And all age groups were affected, and during this outbreak. So let's move on to clinical signs. So obviously you can see the increased temperature, the hypothermia, pyrexia over 105 or 105 degree Fahrenheit. And once you get increased temperature, and you can see some lethargic pigs with respiratory tract, the signs of respiratory tract infection with purulent discharge and everything. So it transmits all over the herd within 2 weeks' time. And the respiratory distress, and some animals show reddening of the skin, reddening of cyanose, ear and snouts and testicles, vagina, vulva, and also you can get high abortion and stillbirth rates. So morbidity is 100%. So almost all the animals get infected within 2 weeks. So you can see some pictures. The pigs having blue ears. So you can see clearly the nostrils are filled with purulent discharge, and the stillbirths and abortions are there. So some vaginal discharge in pigs. So you can see how it has damage to the farms, both farms. The abortion rate was really high. Nearly 90% in the farm A and 100% in farm B. And the prevenient mortality is so high, the 28% in Farm A and 22% Farm B. So the overall mortality rates were significantly high in 37 in Farm A because they have purebred animals. So some in Farm B have crossbred animals. And so initially we get the case, we encountered the case with Farm A. Then we could manage something better with Farm B because 2 weeks later it has affected the Farm B. So probably it might be the case. And disease has existed for a month. And the pathological findings are really important. So the detailed postmortem examination is really important when we are going to deal with pigs, especially. So because early identification is necessary. So we can't wait for lab investigation, right? First, we have to do detailed postmortem examination and identify what is the cause and what are the possible differential diagnoses. So we can see the respiratory tract, the mortal and tank lungs. So most probably the cranioventral lobes are mostly affected. Also, lymph nodes are swollen, and probably endometritis, cystitis, and pinpoint hemorrhages in the lungs are some of the gross pathological findings. So you can clearly see the lungs. It is very easy to identify. The cranial lobes are most affected, and cystitis also there, and the hemorrhages in the kidney and pericardial effusion and pleural effusion are there. So that's the differential based on the clinical signs and postmortem examinations. We have come to different differential diagnoses. The classical swine fever, African swine fever, bovine viral diarrhea, swine influenza, Haemophilus parasuis, insultic pneumonia, porcine parvovirus. There are many of them. And finally, we could confirm the cause of the disease as PRRS, North American strain, by real-time PCR. And the clinical management is the most critical one. So it is not actually easy because the setup is collapsed. So animals are suffering. The people are also suffering. So we have to, as a clinician, we need to communicate both conditions, right? We have to deal with both. So we need to do more, we need to get more control measures with people. So we need to motivate them actually. And once we got the idea of what is the disease, where are we going to face the tentative diagnosis as PRRS. So we went with symptomatic treatments with antibiotics and non-steroidal inflammatory NSAIDs and vitamins. Especially, we use vitamin B12 and butyroscope to enhance the appetite, and vitamin E selenium to enhance the immunity. Also, adequate hydration is needed, and assisted feeding is necessary because they do not eat very well and they don't drink at all. And there are some enrichment programs I tried with watermelon and grass to refresh them and to improve their recovery. Also, intranasal application of some indigenous plants were helpful to reduce the purulent discharge in hospitals. And we use prophylactic treatment of antibiotics and acidifiers via feed, and we improve the biosecurity in the farms through different aspects. And this is second time. First, it has been reported in 2000, and then this is the outbreak happened in last year, and we started using vaccination of animals using modified live virus vaccine for the first time in Sri Lanka. And thank you very much.
And thank you very much, Samira. And the presentation is now open for discussion.
In 2000, first, then the outbreak is first time in Sri Lanka in last year. I think it, probably
having same signs of the
this kind of thing.
The same signs.
All right. Oh, okay. But
yeah, maybe not researching.
It has not confirmed. I think I didn't get any confirmation before that. Yeah. Yes. Before that, in NLDB farms, so in the field there is an outbreak reported, but I didn't have any opportunity to encounter. But finally we got that. then that we could encounter this problem.
Maybe out of your expertise, but has this been reported?
Probably, but I don't have any idea about that. Probably they may resistant or something like that. I don't know exactly until then.
Okay, there are a couple of questions. I want to prioritize them. Hello?
Current situation. Now it is under control. We vaccinated 2 times. Initially in January, the vaccination we started in January, and then we boosted the vaccination in last month. So now it is under control actually to now. I can't say that because we need to monitor it.
Because it is having that vaccine is effective or not.
Okay, I don't know because in our farms we got the case in last year November. Lasted 1 month period, and then we started vaccine when the animals were completely recovered, and then in January we started vaccination initially, and then we did the first booster vaccination last month, and we'll see what will happen. And we collect blood samples to monitor T levels actually. Yes. But in Sri Lanka, it is now not available, I think. So we have to send it to the other laboratory somewhere else.
And Samira?
Yeah, the samples were sent to the VR. Actually, they did RT-PCR there. PCR, yes.
Samira, there are a lot of questions. I'm going to prioritize few of them and ask them from you. Can you hear me?
Yes.
Yeah, so one question is, what is the source of the infection? And the other one is, what are the provinces reported with the disease? Can you answer those?
Sorry?
They're asking
source of infection.
Source of infection, and what are the provinces that are reported with the disease?
Yeah. So we confirmed the disease in 2019 in the end, actually in December or January probably. Once finished the disease actually in the farms. So the laboratory results came later. And also in previous months, since April or somewhere else, so as I said earlier, there were cases in the field which was unconfirmed, right? Okay. So probably the cause of the disease might be, there are some, because we are handling breeder herds in our farms. So some people, they lost their herds during these outbreak in their farms, and they came into our farm to bring the animals, to purchase the animals probably. That might be one of the causes.
Okay, and there's this one interesting question. This is going to be the last question. What is the mode of action of intranasal application of mukunwanna extract?
Yeah.
And then Dr. Janith is asking, is this a holistic approach in treating pigs?
Yes. So there is no option with the mucus purulent discharge in the pigs. All animals are sick. They lie down and they can't breathe. So whatever I search and I ask from, actually I asked from my mother-in-law, there is a drug of giving for the human also. She has a drug. So I asked her, so can you give the recipe of this? And I will try that with the pigs. So I did it, but it worked. Yes.
Okay, thank you very much. And then let's conclude the presentation with that. There are so many questions. Maybe we'll forward it to you and then you can write to those respective vets on their questions. And the next paper is on cesarean section in swine. 2 cases of dystocia due to feto-maternal disproportion. It's authored by WASM Premaratna, T. Adhikaran, KG JS Disnaka, and PGA Pushpakumara. Again, Dr. Samira will present the paper.
So uterine inertia, there are several causes for dystocia in pigs. One is uterine inertia, and there might be some deviation of the uterus because the uterus of the pig, the sow, is quite long and very big, comprising many piglets inside, probably 15, probably 20 even sometimes. And sometimes the filled bladder might interrupted with the delivery of pigs, also uterine torsion, that is twisting of the uterus, and feto-maternal disproportion. Then now these 2 cases were built because of the obstruction of fetuses due to feto-maternal disproportion. And also the cesarean section is very rarely attempted in swine in Sri Lanka. I don't know previously who did it. And let's move on to the case presentation. And 2 cases were encountered during this during my career, and one is U.o.P, which is a gilt actually going to birth, primiparous sow, and one multiparous sow. And the location is actually in the Horakale farm of National Livestock Development Board, and surgery done on the general anesthesia. We use ketamine silicin combination and lignocaine infiltration along the incision line. And the interesting thing is we need to keep the animal downward, head downward with the 30-degree angle to avoid the pressure of internal organs with the uterus, because the uterus is very heavy compared to pig. So we need to avoid the pressure from other organs too. So that's why we kept animal head downward with the angle of 30 degree. And initially we medicated pigs with long-acting antibiotics and NSAID, flunixin, and surgical site was left flank to avoid bleeding. And site was prepared by shaving and applying povidone in isopropyl alcohol, as usually we do in small animals also, we did do that. And you can see the incision, which is longitudinal vertical incision in the left flank. And fetuses can be taken out through the same incision by like in the third picture, you can see the piglet which I took out. And the closure of the uterine incision, we do it continuous Lambert pattern with the absorbable suture material. And similarly, we close the incision using, we need to infiltrate long-acting antibiotics along with the incision line and prior to closure. And peritoneum and muscle layers, subcutaneous tissue, we sutured using nylon, simple interrupted pattern, and skin was, we used Ford interlocking suture pattern. And the post-operative management is important. We need to do daily wound dressing, and also long-acting parenteral antibiotics are necessary because pigs are in because the environment is not clear, not clean actually, because we need to give parenteral antibiotics, long-acting, and pain management is important, and flunixine we used, and to improve the immunity we used vitamin E and selenium, and the prognosis was good. Thank you very much.
Thank you very much, Dr. Samira, and the paper is now open for discussion.
Dr. Samira, because it is the first time and when did you do this?
A couple of years ago.
How about the fertility? How about the how?
But after that, the conception was not good. So because there is, I think because of the animals are lying in the dirt, and the contamination, because they are always lying in the floor, and they urinate and everything, they are there. So probably because of that, the uterine infections are possible sometimes. Because of that, we think the fertility would be lower because of that. Yes. Life-saving surgery, yes.
So after that, curbing? Or?
Yes, now a couple of years ago. So with the productivity, and we assess regularly with the productivity of animals. Because of that, we need to adhere those regulations usually follow in the farms. Yes, but it is not that much. Yes. The site is really, yes, fat and less bleeding actually.
And Samira, Dr. Dhammika Perera is asking, what was the exact dose rate of ketamine you used? Not the dose range. He's asking for the exact dosage.
Ketamine 11 to 30 milligram per kilogram we can use. So now in Sri Lanka, there is a small animal product. I can say the name, the Catexil, I mean. Yes, we can give 100 per 100 kilogram, 1 ml, I think. It works. So it has both ketamine and psilocin.
And then there's a question from Dr. Janit again on, you mentioned about that the environment is not being clean, but he's asking even at the livestock level, the environment should be clean. What is your comment
environment level clean, but in the environment with pigs, usually we need to clean it, right? So it is not like in the room. So like we stay in the dogs or some other companion animals. But with the pigs, we usually, our farm is one of the cleanest farm in the Sri Lanka. So I assure them.
Okay, so with that, we'll conclude this paper, and then thank you very much, Samira and your research team with those two papers on swine. And on behalf of all the veterinary community, we thank you a lot, because swine industry is a very important industry that has a huge potential to grow in Sri Lanka. Thank you very much.
Thank you very much.
So now from swine to bovine, we are moving on to our next paper, traumatic abdomasitis and perforated ulceration associated with foreign body ingestion in a pregnant cow. Paper is authored by PGAS Palkumbura, SACH Rodrigo, GDRK Pereira, GSPDS Gunawardana, and RRMKK Vijay. The paper is presented by SACH Rodrigo.
Good afternoon, everyone. My name is Chaturi Rodrigo. Today, I'm going to present a rare clinical case which we came across during a post-mortem. Well, among all the farm animals that we know, cattle show the most indiscriminative feeding behavior. So due to this indiscriminative feeding pattern, they ingest a lot of foreign bodies through their feed. So these foreign bodies can lead to two main outcomes in cattle. Basically, as we know, it could either lead to traumatic reticular peritonitis, or it could either lead to traumatic reticular pericarditis. Well, have you ever wondered that these foreign bodies can cause traumatic abdomasitis as well? Yes. Today, you are going to witness a case of traumatic abdomasitis and a perforated ulceration associated with a foreign body in a pregnant cow. So let me give you a brief introduction about the background of this disease. So we simply call it as foreign body syndrome. So it's a very common problem worldwide. And it is caused by the ingestion of indigestible, metallic or non-metallic, blunt or sharp objects by these cattle. So there are many predisposing factors for this particular condition. And out of these factors, indiscriminative feeding pattern is on the top of the list. So as we know, cattle do not possess any specific sensitive lips, prehensile organs to ingest their feed. So due to that, they ingest a lot of foreign bodies. So in addition, we can suggest several other predisposing factors like low quality feed ration, feed scarcity, poor animal husbandry management, industrialization and mechanization of the agriculture, and environmental pollution. Okay, so as I already mentioned at the beginning, there are two main common sequelae for this condition, traumatic reticular peritonitis or traumatic reticular pericarditis. So as a rare clinical incidence, traumatic abdomasitis could also occur. So let's look at the traumatic abdomasitis. Simply, abdomasitis is the inflammation of the abomasum. So the etiology, abomasal impaction, ruminal acidosis, and enterotoxemia associated with Clostridium perfringens. And also similar to this case, traumatic injury due to foreign body ingestion can also cause abdomasitis. However, traumatic abdomasitis is rare. So why is it rare? So these, the reasons for this low incidence rate are mainly the anatomical features of the complex stomach. So as we know, anatomical location of the reticulum is so specific. So all the swallowed indigestible material will be accumulated in the reticulum, and it will be deposited in the ventral part of the reticulum, and also the elevated location of the reticulomedullary orifice, along with the unique honeycomb appearance in the reticulum. So due to these reasons, due to these factors, traumatic abdomasitis has become a rare condition. Well, let's look at the case. It was a 4-year-old, 8 months pregnant Holstein Friesian cow. An animal had gone through a short clinical course of around 5 days. So on the day 1, animal had developed anorexia, depression, and high fever of about 106 Fahrenheit degrees. After 2 days, on the day 3, animal gave birth to a fully developed dead calf, and farmer had suspected it as bovine babesiosis, and the animal had been treated with diaminosin aceturate. However, animal died after 2 days, and a detailed necroscopical examination was performed. So let's look at the postmortem findings of this case. So external examination did not reveal any specific lesions. We only observed pale mucous membranes along with severe dehydration. And internal examination revealed several important lesions. We observed deep brown serous fluid of about 200 milliliters in the peritoneal cavity. And there were several lesions on the omentum as well, such as diffuse fibrinous thickenings and multifocal, ecchymotic and paintbrush type of hemorrhages on the visceral surface of the omentum. And also we observed a large amount of ingesta in the abdominal cavity. So this is the picture of the omentum, the visceral surface of the omentum. So these red arrows show multifocal, ecchymotic and paintbrush type of hemorrhages on the visceral surface. So abomasal lesions were quite interesting. What we observed most was the severe abomasitis along with the perforation. The perforation was a linear one with a length of around 6 centimeters, and wall was highly thickened and mucosa was darkly discolored. And also we noticed multifocal ecchymotic hemorrhages. And very interestingly, at the area around the perforation, there was a locally extensive ulcer, about 8 centimeter diameter, of the abomasal mucosae. So this is the abomasal mucosae. So if you look at the asterisk, you can see the locally extensive ulcer, and above that you can see the perforation, which is shown by the arrow, and the arrowheads show the chronically affected mucosae, which was thickened and darkly discolored. Well, on the omasum also we noticed multifocal ecchymotic hemorrhages, as you see in this picture. So very interestingly, we found a metal wire of around 6 centimeter length. It was found at the pylorocranial duodenum, and it had penetrated into the peritoneal cavity through the wall. So these are the other things that we found. Actually, rumen and the reticulum, we didn't, no abnormality were detected. And also liver, kidney and spleen were also normal. And in the thoracic cavity, lungs showed severe diffuse pulmonary edema. And also, no abnormalities were recorded in the diaphragm, heart, or the pericardium. So let me put all this information in this way. So the initial stimulus is the foreign body injury to the abomasal wall. So it might have caused the traumatic abomasitis and also the abomasal perforation. So after the perforation has occurred, it can lead to the leakage of ingesta into the peritoneum, and also it can cause acute severe diffuse peritonitis. And due to peritonitis, animal can develop anorexia and fever, and also high fever can lead to the stillbirth of the calf. So let me conclude all what I have said so far. So diagnosis of abomasal ulceration and traumatic abomasitis is quite challenging in live animals due to lack of specific clinical signs and the rare incidence of these cases. However, so what can we do? When we make a differential diagnosis list, we have to include traumatic abomasitis, and when all the other DDs are ruled out, traumatic abomasitis should come into our consideration. So, and after that, immediate laparotomy should be performed and the abdomen should be explored to prevent the possible movement of the foreign body throughout the GI tract. So I would like to extend my sincere gratitude to these valuable personnel. Thank you.
Thank you very much, Dr. Rodrigo. And I would like to open the discussion with a question from our online audiences. Dr. Janith is asking, did you mention that the farmer treated the cow for tick fever? Is it that didn't he have access to veterinary services?
That's a very good question. Actually, this farmer is not taking veterinary advices from any veterinary surgeons. He's suspecting some diseases and giving the available drugs that he has. Due to high fever, the farmer has suspected this as bovine babesiosis, and he had treated with Berinea.
It's a very interesting situation. I think a problem that our veterinary community has to address as soon as possible in our country. Okay, any other questions?
Abominable ulceration and perforation of abomination are two conditions. Right? What it means by acute ulceration or perforation of
So we actually noticed both of these conditions in this case. The point where we observed the perforation, there was an extensive ulcer as well. So initially the ulcer had occurred and it might have led to the perforation of the abomasal bowel.
Different in the wire for 5-6 centimeter wire. Please repeat the question. Well, I'm also in the same opinion as Dr. Silva. So ulceration might lead to perforation, and then what you have mentioned, maybe the wire is pyloric, isn't it? The pyloric area. Maybe too, I mean, I can't really say that the wire really caused the abomasitis and then the perforation and ulcer. Maybe two different things.
Yes, actually, this farmer, they said that they bought a very low quality dal mixture few months back, and it had many metal impurities. So before this case also, there were several cases of traumatic reticular peritonitis and pericarditis. So we were called upon for the performance of necropsy only for this case. So, but they have noticed it's throughout this past period, and they suspect of the dal mixture, and also after they have withdraw this dal mixture, also they got these type of cases. So that was the only foreign body that we noticed at the time of the necropsy, but there might be many small metal parts and other things in the abdominal cavity with the ingesta, because we noticed a lot of very large amount of ingesta in the abdominal cavity intermixed with the other organs in the abdominal cavity. So this the chronic nature of these lesions are mainly due to those impurities, I guess.
Okay, I think there's time for one last question. Dr. Nimal Javeer asking, how can we recommend exploratory laparotomy for all cases showing these clinical signs and symptoms? Any other alternatives?
Yes, before performing exploratory laparotomy, we can actually go for other diagnostic methods, which I didn't mention. We can perform ultrasonography, radiography, and after that, actually we have to go for laparotomy. So sometimes these metal parts would not be detected by any other diagnostic methods. So I would suggest first we have to use the diagnostic aids, and then we can go for a surgery.
Okay, thank you very much. And with that, we'll conclude the paper. And,
thank you.
And let's move on to the next paper. It is the title is on primary leiomyosarcoma of a genital tract in dogs. A report of 2 cases. Paper authored by Dr. C. Abeykon, K.A.R.K. Pereira, H.M.S. Vijayakon, and D.D.N. De Silva. It will be presented by Dr. C. Abeykon.
Okay, good afternoon, everybody. And let me share with you
a story of two champions who survived, who defeated all odds and survived quite dangerous tumor conditions that are really occurring in dogs. So I'll be talking about primary leiomyosarcomas of the genital tract in dogs, and I'll be presenting two cases today. Now, before we move into this primary leiomyosarcomas, just an insight, just an introduction of what this totally is. Now, basically, leiomyosarcomas are they're slow-growing, locally invasive malignancies. And today in my discussion, I'll be going through vaginal leiomyosarcomas and uterine leiomyosarcomas. And if we look at the commonest vulvovaginal tumors, leiomyosarcomas tops the list, followed by TVTs and squamous cell carcinomas. But the thing is, these primary tumors of vagina are very rare. Only 2 to 3% of them are seen. And also out of them, about 20 to 30% of them are malignant. And also, you find vaginal malignant leiomyosarcomas to be non-pedunculated and recurrent. Now, when we look at the uterine tumors, they account for about 0.4% of all tumors of dogs, and leiomyosarcomas especially account for only 10% of uterine tumors. So this shows how rare these leiomyosarcomas, either of the vulvovaginal origin or of the uterus, are. And I also want to highlight on endometrial hyperplasia. This is a complex. Endometrial hyperplasia and endometrial tumors together are very rare. And when we look at the literature, it provides a very dearth of knowledge. Literature is reported. Now, first case is of Milo. He was a true fighter, a 13-year-old female Labrador. Now, he was presented to the Better Teaching Hospital at several instances. First, in 2017, it was diagnosed with TVT and we treated with vincristine. And after about 6 months, it comes again and we did a surgical excision. And once again, in May 2018, another excision. And it comes for the third visit. Once again, we perform a surgical excision of this perineal mass. Now, Milo was having a perineal mass and it was excised. Now, let me go in detail to this third visit of his. Upon the general clinical examination, we found a mass on the perineal region and it was difficult to catheterize and it was suggestive of a partial obstruction of the urethral opening. And we went for further diagnostics. There was a clear and obvious cystitis, and even radiological examination showed that there was a soft tissue growth. And we wanted to surgically remove the excision. We've used diazepam and propofol as pre-medication anesthesia. And then we surgically excised them, the lesions. So a few little bit glossy images, how it was placed using electrocautery. We used them, and finally it appeared like this with the catheter, female catheter intact. As antibiotics and pain management was done with meloxicam, and we started antibiotics as well. Now, the samples were sent for histopathology, and the report came as a leiomyosarcoma of the perineal mass. And there were changes of tumor lesions were found of a leiomyosarcoma. And then what we did was, since we received this, it was diagnosed as a leiomyosarcoma through histopathology, we initiated chemotherapy with having discussed the pros and cons with the clients. And this was the protocol that we followed with cyclophosphamide, prednisone, and vincristine. And this is the important part, the subsequent visits of Milo. Now, after 2 weeks of post-operative, there were no abnormalities. Then he comes once again in 6 weeks, anorexia, hematuria, the condition is not getting any better. But remember, he's after 3 surgeries, having the cancer for 2 years. 7th week, he comes anorexic, bleeding from the suture line, abdominal enlargement, quite an unpleasant sight. So we had to put him down, and we'll discuss further how that decision was reached. And we also, during that visit, we had ultrasonographic examination performed, and we found severe cavitated lesions in the liver, suggestive of a metastasis condition, but the bladder was doing quite well. And these, after euthanasia, we had performed necropsy, and these the lesions that we found, quite generalized, devastated liver we could find. And once again, these samples were sent for histopathology. Now, this is the lungs, and this is the liver. What was interesting is that when we got this report of histopathology, we found it saying that this is suggestive of a metastatic lesion of a carcinoma. Now, we got the first report saying that it's a primary leiomyosarcoma that is occurring in the, at the perineal region, whereas these results come out as a metastatic lesion of a carcinoma. So that is also something that we'll be discussing in the discussion area. So next, we'll go to the second case, which is Tasha. Tasha was a 6-year-old Labrador retriever. She was a true survivor. And upon the case history is that it came with a complaint of bloody vaginal discharges, diagnosed as a TBT, treated, it resolved, but once again came back in 2 months, and TBT had been ruled out. It was negative in the smears. Scanning was performed, and we found that there was thickening of the uterus and the vaginal wall, and we wanted to perform an ovarian hysterectomy, and then we sent samples for histopathological examination. There were repeated visits, but there were no signs of metastasis as we performed radiological and ultrasonographical examinations. Hence, we did not initiate chemotherapy. So these are the findings of Tasha, the second dog I'm talking about. There also, we got a report from histopathology, and these slides also indicate that it was a leiomyosarcoma plus cystic endometrial hyperplasia. So this is a combination that is very rare, so rare that it's very difficult to find this sort of literature, even in many sources. Let me spend some time on this because I think this is the gist of what I was presenting today. Now, Milo's case, as I said, I hope you remember, he was a 13-year-old dog who underwent surgery thrice, who underwent chemotherapy, and before initiating chemotherapy, he had a good life, having undergoing this surgeries thrice. And also, Milo was having extrauterine tumor lesions. He was having lesions in the liver as well as in the lungs. But I hope you remember when I said that the report said that these were not metastatic lesions of the leiomyosarcoma. Then that itself brings to discussion, can carcinomas and sarcomas occur concurrently in dogs? Once again, a claim that is not very well supported by literature, because I also could not find so much of literature saying that carcinomas and sarcomas could be found concomitantly in dogs. But here we have found a case where sarcomas and carcinomas occur together. But that's another possibility. Did we miss a primary carcinoma in our necropsy? But I don't think so, because there were no such visible, obvious signs of other tumor lesions other than in the perineum, liver, and the lungs. Decision of euthanasia. I think this is something that we want to discuss openly. Patients as such who have lived where quality of life is of utmost. If it's that, we should do that, because quality of life is what we should promote. Milo had a marvelous life of almost 2 years, but he had to give up after about 2 years, and we had to put him down. Tasha, on the other hand, it was a fair play. I mean, she managed with surgery alone, and there were no extrauterine tumor lesions, no signs of metastasis. Surgery alone could improve her quality of life. So from Milo's, we find a concurrent carcinoma and a sarcoma, a very rare finding. And from Tasha, we find a leiomyosarcoma with cystic endometrial hyperplasia, perhaps a first-timer in a Sri Lankan context. Ladies and gentlemen, the take-home message that I would let online viewers and the ones present today, that surgical intervention remains the best option for vaginal or uterine leiomyosarcomas. And chemotherapy, initiation of chemotherapy should be prudently thought of. It's not something that you can ad hocly start, and especially proper consideration should be given to the location, the level of metastasis, and etc. And most importantly, there is a possibility that carcinomas and sarcomas can occur in dogs. And I'm sure the future will answer to that question. So thank the following individuals. Thank you very much.
Okay. Sorry, Chandra, my microphone was muted. So there's a question from online audiences. Dr. Thanuri Ediritilaka is asking, the two patients you were talking about, were they intact or neutered?
Yeah.
Did you use cytology to initially diagnose them as TVT?
I didn't get the second question.
The second question is, did you use cytology to initially diagnose them as TVT?
Yes. The first question, Milo was neutered. Tasha, the second dog, who's still surviving, was intact. And I must say that literature says that leiomyosarcomas are hormone independent. So that is also something that I think I should highlight. For the second question, TVT was diagnosed via cytology, yes.
Okay. Thank you very much. I think we have very limited amount of time, and then we will conclude the paper at this point, and we'll move on to the next presentation.
Thank you very much.
Thank you, Chandra. And the next paper is on co-infection of avian metapneumovirus and infectious bronchitis virus in a large-scale broiler farm in Sri Lanka, a case study. Paper is authored by N.D. Silva, M. Paniago, and I. Kiss. The paper will be presented by Dr. N.D. Silva.
Good afternoon, ladies and gentlemen. I'm Nalin D. Silva. I'm working as a poultry veterinarian in Sri Lanka. I'm going to share some information about swollen head syndrome in broilers. This is quite important case as there are no such information available up to now about involvement of metapneumovirus in chickens in Sri Lanka. Here, both viruses are involving both metapneumovirus and IBB are respiratory viruses. They cause much similar symptoms like upper respiratory tract infections. If we consider about metapneumovirus, it has 4 subtypes. Subtype A, B, C, and D. Out of that, subtype A and B are common in Asian region. Other than that, if you talk about IBB has different pathologies, like because IBB has different tissue tropism, so IBB can cause some infection, the other infections in kidneys and reproductive tract in chickens. Let's talk about a little bit about clinical manifestations of metapneumovirus and IBB. As I said, both IBB and metapneumovirus cause upper respiratory tract infections in chickens. Both these viruses are very highly contagious diseases, and also both viruses. There are reports about swollen head syndrome. Both these viruses are have some involvement in swollen head syndrome. And as I said, as IBV have some different tissue tropism, it is causing nephritis and infections in reproductive tract as well. And let's talk about the case. This case was found in North Central Province, and mortality was increasing. This is a environment control farm. They have 10 houses in the same farm, and mortality is starting from 26th day onward, and mortality was about more than 88% at the end of the clock. And interestingly, the flock has been vaccinated with IB. So this is why we thought about there can be some other factor involved in swollen head syndrome. So given fact that the birds are having symptom like swollen heads, so this is why we thought about avian pneumovirus involvement in this particular case. And we take into account that what is the biosecurity situation in the farm. So there are so many biosecurity defects in that farm, but most importantly, I would like to highlight 3 points. One is the farm is multi-age, and the other one is they have thinning out system. In this case, hatching crew and most of people mounts are very much high in this kind of farms. So introduction of diseases and spread of disease can be quite high in this kind of system. And the other important thing is, in this particular case, IB vaccine, they have done IB vaccination, as I said, but the IB vaccination had been done inside the farm using non-standard equipments, using normal spray equipments. So these 3 points are very important in this particular case. And the objective of the study was to conclusively diagnose the causative agent responsible for the clinical condition, and also highlight the involvement of avian metapneumovirus in chicken respiratory diseases. So we took clinical science and history, this information into the account, and we did postmortems, big number of birds in from all the houses, and then we took samples from few houses for ELISA. We did acute and paired serum ELISA, acute and convalescent serology for all the differential diagnoses we considered: IB, avian metapneumovirus, Newcastle disease, and avian influenza. Then molecular detections was done in Sivapilaxia laboratory. We took samples to the FTA cards and sent to this lab for RT-PCR and molecular sequencing. These are the clinical signs we observed mainly. There was a profuse symptoms like swollen head and nasal discharge and prostration and death. Deaths were very high. And if you see these pictures, you can see eye discharges, some frothy eye discharges, which may indicate the signs of avian metapneumovirus. And necropsy symptoms, they are general symptoms, and one thing to highlight: the serofibrous exudate due to subcutaneous edema in the head, and the secondary infections by other bacteria. And general upper respiratory tract infection, symptoms of upper respiratory tract infections can be seen in this.
Yeah. So we have to.
And these are some other symptoms of postmortems: nephritis and some hemorrhagic lesions in cecal tonsils also observed. And these are the results from paired ELISA. We took samples from 28 days and 37 days. We saw in IBV ELISA, we saw about 6-fold increase in conversion serology. Seroconversion is like 6 folds compared to 28 days. And for avian metapneumovirus ELISA, paired ELISA, it was like 5.5 times increase in titers. And we didn't see any significant seroconversion against ND and avian influenza antibody titers. And these are the RT-PCR and sequencing results. We didn't get any positive results for metapneumovirus, NDVO, AIV, and Mycoplasma gallisepticum and Mycoplasma synoviae. But RT-PCR and sequencing was able to detect IB variants. 3 IB variants belongs to 793B genotype, and another variant closely related to H120 strain of IB. Let's move on to the discussion. Based on clinical picture, necropsy, and serology, we made tentative diagnosis as IBV and metapneumovirus. Then significant level of seroconversion for IBV metapneumovirus was demonstrated by ELISA, confirming the involvement of 2 viruses. And the chick have been vaccinated with IBH120. So that is why we thought again about involvement of some variants. So RT-PCR confirmed the involvement of IB variants in this disease process. And RT-PCR results were negative for avian metapneumovirus. This is because there are 2 reasons for this observation. One is presence of IBV in the respiratory tract and other organs will mask the avian metapneumovirus detection. And the other thing is, there's a characteristic in avian metapneumovirus, virus will replicate and signs will appear after replication completes. Virus lasts only 6 to 7 days maximum in the sinuses and turbinates, nasal turbinates. So this is why it is difficult to detect in this kind of cases. It is difficult to detect avian metapneumovirus in chickens. So other thing is effectiveness of IBV vaccination was doubtful. As I said, they have done vaccination in the farm using unstandard equipment, and there were some secondary bacterial invasions as well. My conclusions: the significant level of seroconversion observed in convalescent and acute and convalescent serology suggests avian metapneumovirus involvement in this case. And paired ELISA and RT-PCR confirms IBV involvement as well. And in total, we can conclude that poor vaccination might be the reason to expose these birds to IBV first, and the birds might have get metapneumovirus infection secondary to the IBV. Thank you very much. So the current work and future plans are ongoing. We are going to molecular characterization and phylogenetic analysis for metapneumovirus in future.
Thank you very much, Dr. Nalin, for that very technical paper on poultry. I will start the questions with one of the questions that we have online. Dr. Tilini Anupama is asking, which strains of IB are currently in the IB vaccine?
It is Massachusetts type H120 strain was used. They have used this type of strain only at that time.
Okay, and then there's another question from Dr. Ishan Veerasinghe. Did you find any relationship between identified IB variants and vaccine variants? Variant vaccines available in market?
Actually, in this case, we usually suggest if you find variants in a farm, we usually suggest them to use variant vaccines to get the protector type protection. But in this case, they didn't agree to go for vaccination at once because of the cost concerns. Then we tried to streamline the vaccination because they have done the vaccination in their farm using non-standard equipment. We did the same vaccination using standard equipment, and we improved some biosecurity. So the case was okay after that.
Okay, and then I will allow one more question from the floor.
I didn't find, madam, I didn't find any information.
before regarding
in this farm?
In this farm, in the country?
No. Actually, I didn't find, but I'm seeing some cases recently. Actually, before this, I have seen one case, and it was not done as a study, but this was done in a formal way. But there are some cases, symptoms like swollen head syndrome, and I'm trying to find out do the PCR and characterize the virus. Actually, right now we don't have any vaccines available in Sri Lanka about for avian metapneumovirus, but for IBV there are vaccines. But in future we might have to get if the prevalence is very high. But there are seasons like yes. Actually, I'm going to study about the field cases because these cases are very much prevalent in hot season, like May, June, like periods. So we may get April, May, like we may get more cases in this period.
Okay, so with that.
Yes, actually, metapneumovirus has different etiological agents. It's a syndrome, so it has sort of factors to be involved, like ventilation and some other viruses, bacteria, many things. Yes. Rhinotracheosis is. Yes. It's the first isolation was done in Turkey.
Okay, with that we will conclude the paper, and then there are so many questions that is coming from Nalin, and I'm sure you can ask them when you meet them in Sri Lanka when you're traveling everywhere, right? There are so many questions on the online forum. So with that, we will conclude our clinical session of the 72nd scientific session of the SLVA. And it has been a wonderful session with a great diversity with so many different species, and then a lot of technical papers. And we should thank everybody who was involved in giving technical support. And then it was a very new experience for everybody. And I think as a whole, our veterinary community in Sri Lanka should be proud that we could conduct a session like this. And then let's look forward for more papers in the rest of the day today and on 5th of July. Thank you very much. And then let's conclude the session. I hand over the microphone to the compeer.